morning, everyone. We are here to talk about management of thyroid nodules. Thyroid nodules are amongst the most common endocrine manifestations in our day-to-day presentation, day-to-day clinical practice. The prevalence is increasing in this era of high precision, high resolution imaging. Now, most of the nodules are benign, but these do give rise to significant amount of anxiety in our clinicians and our patients. There are many unanswered questions, the key being who needs evaluation, who needs intervention, and how should we avoid unnecessary procedures without missing out malignancy. I think this session will strike a balance between vigilance and intervention. I would like to hand over the mic to Dr. Shenoy, sir. He needs no introduction, he is quite famous. Sir, jokes apart, sir, the floor is all yours.
Thank you very much. Thank you, dear SK Singh, sir, and thank you, the organizers, for giving this opportunity to me. I have been using AI in a view. I have also done some publications regarding how we can place AI for thyroid nodule estimation also, which in my center I am trying to implement. So that's some slides which I will include in this. So first my thing is that this is the best opportunity because the first Bihar National State Conference, so I wish them best of luck for the future endeavors. So really I appreciate your endeavor to have this at a very good location. So thank you for having me. So learning objectives of today's lecture, we understand the epidemiology of thyroid nodules, we review diagnostic workup. As I told you, we should know ultrasound risk stratification systems, applying the existing diagnostic criteria, and as evidence goes, experience also growing, so we need to follow algorithms as well. So what is thyroid nodule? Thyroid nodule is a distinct lesion within the thyroid which is different from the radiologically from the surrounding thyroid parenchyma. So it can be a solid or fluid filled lump within the thyroid gland. It can be solitary, it can be multiple, otherwise it can be functional or non-functional. That means structural, functional, anatomical, everything has to be kept into consideration. This is the ATA definition of thyroid nodule. Classification, it is benign and malignant. If person asks you, Doctor Sahab, mere gardan mein ek thyroid hai, so we can say everybody has thyroid. Thyroid nodule hai, so differentiate between them. That is the benign and malignant. So it can be a colloid nodule, it can be a cyst, it can be part of thyroiditis, it can be pseudonodules of thyroiditis. And second side, it is malignance or not. So malignancy are definitely most common type is papillary carcinoma thyroid. Luckily, it is actually manageable many times by surgery alone. So you need not go for any other therapy, just surgery alone can be curative. But other ones which are not having great prognosis are the follicular, medullary and anaplastic carcinoma. So just a case presentation, a 32-year-old lady presenting with a thyroid nodule. Initially thyroid was found incidentally. It's called incidentaloma. Matlab, दूसरे जगह से आया था, just for seeing the nodule, they found they have a thyroid nodule. So the patient is requested to have a thyroid ultrasound, found to have a 2 centimeter nodule in the right lobe of thyroid gland. As you know, ultrasound emits non-ionizing radiation, sound waves, and you can pick up nodules quite early. So the very early stage you can pick up by ultrasound. So I think, what will you order first? I think majority will you agree that you have to be sensible. You should order thyroid function test before you comment on the type of daughter. What do you know whether it is harming the patient or not? But some people do all of the above. Because some people tell, sab kuch kar lo, main baad mein dekhunga. So it's not the way to do. It's showing you that holistically and pragmatically you should go by systematically. And if you are finding structural issue, go for higher investigation. If TSH is low, go for iodine scan. That is what I will tell in the future. So basically thyroid functions are important to understand how they are active or not, whether they are functioning normally or not. Local symptoms have to be excluded because you should know hoarseness of voice. I have a noise issue solved because I had a bad travel issue. So my hoarseness of voice is also one of the known typing happening. Difficulty to swallow, dysphagia, and foreign body sensation. Some people may tell they have a difficulty in the neck area. Something is happening in the neck. I am not understanding that. So there may be one clue for that as well. Malignancy, maybe you should understand by using the existing technology available. So genetically understand that age below 20 years and age above 70 years are predisposed for having risk factors. And malignancy of thyroid in the family, including the MEN2 syndromes, have an important threshold. Environmental deficiency, as the Zargar sir is also here from Kashmir, so many experiments have been done from Kangra Valley. We know that we have reduced incidence of goiter, but we have some people have thyroiditis. because iodized salt has been used exponentially and more than what is required. That is a controversial area. But generally, it is protective in nature. Iodized salt is good, but you should understand iodine deficiency rates are not now seen because majority of us are using iodized salt only. Understand that historically, iodine deficiency is known to be a major factor in the thyroid pathogenesis. Exposure to radiation. I come from an area where we have some industrial areas. We have got seaside area. There is a place called Karunagapalli in near Trivandrum or near Kollam, where so many people have got thyroid nodule because so many factories historically had titanium or some other chemicals. Ionizing radiations are also known to be in that area. Now, after vigilance and so many years of study by RCC, in our Trivandrum we have got RCC, we have found that we are able to arrest the incidents by addressing the factories to dump their waste correctly. So now we are able to address that better. That is the importance of public health in the practice. Hormonal changes. One of the next speakers will tell about the thyroid and pregnancy. I will not touch upon that. So palpable nodules are 4 to 7%. Ultrasound can detect 20 to 70%. Higher prevalence in women, elderly, iodine deficiency, summarizing the slide. 5 to 15% have a risk of malignancy. So not every nodule can have a risk of malignancy. So this is a very important point to be noted. So demographic, this is the data published in the American Journal from way back in 1960s to as recently 2010 also. So this is the data showing that we can diagnose early, the yield is better also. But what will you do when you diagnose early? You should follow them up. So what is the goal of assessment of nodule? You should understand the risk factors. You should do screening protocol. If it is required, go for surgery. Don't go for surgery in the every thyroid nodule. So radiation exposure, I have told you, rapid growth, hoarseness of voice, cervical lymphadenopathy. So presence of another area nodule, not reactive lymph nodes, pathological nodules can be a risk factor. As I had told you, MEN 2 syndrome and family history of cancer is a very important thing to be assessed as well. Physical size, more than 4 centimeter in size, hard in consistency, fixed nodule, vocal cord palsy, these are the major things of physical things. And the speed of malignancy progression, that is regional and distant. These are all early. This is published from 2012 publication. So detailed history, I have told you, compressive symptoms, increased risk, these are all to be taken into consideration. Next, come to palpation. You should ideally palpate in front of the patient and also from behind and ensure that you are doing it in the proper technique also. And don't keep on palpating. I think if you are students palpating, palpation itself can cause thyroiditis. So I have seen so many students palpate. मुझे पता नहीं चल रहा है तो बाद में कर लो. I will tell. Don't do again and again. So that is known to happen, but theoretically you should definitely palpate it in the appropriate manner and understand if fixation is not or not. And lymph nodes have to be also checked. So you should understand differential diagnosis of thyroid mass also, anterior neck masses. Majority are benign lesions. Some are congenital. Some people don't know how long it were. They include some tonsil, they have some issues also. Thyroglossal cyst that moves with the tongue movement. That's also one thing to be noted. Inflammatory causes and other causes are also known to happen. This is where we should know about the lymph nodes of the neck. So many lymph nodes are there. So we should know which area lymph nodes are draining which side. This is for planning for a long term. We should know what type of nodules you are finding. The submental and the jugulo-digastric can be even physiological, but other things can have an association. Thyroid area, we have got the pre and paralaryngeal lymph nodes. So summarizing my first half, that is understand that neck fullness and thyroid nodule are different. If you are finding a distinct area, just palpable and nodule has been pathologically understood, then you should go for the higher investigations also. Respiratory symptoms and voice changes are also known to happen, and swallowing difficulties can be one of the presenting symptoms. Odynophagia or choking sensations can also be occurring. So how to examine further? That is the hands behind the neck, head and head neck section. This is called a Pisello method. And you can even find the trail sign. Trachea is deviated towards the which side? That is the opposite side most likely. And palpation always behind the patient is confirmatory to characterize the nodule swelling. Look for retrosternal extension, cervical lymph nodes and shift of the trachea. Front of the patient, very commonly we do it, but it is done only in reserved cases to look for tracheal shift. It's called Lahey method. And complete it by doing the Pemberton sign, because it's very important to know. I recently had a patient coming with, not this patient, it's just a historical fit photo. They can be called the cork effect. So the thoracic inlet syndrome, superior midicastine, they have the issue. It is classically seen in retrosternal. 30 seconds itself, head raising, you can find the issue. So now coming to the next stuff, how to evaluate further by using radiology. Highest percentage is found to be helping with the ultrasound neck. Now elastography and AI techniques have found higher yield with ultrasound itself. So that gives you a better edge over the palpation, and you can see CT and MRI, and sometimes so institutions do FDG PET. Some FDG avid nodules can also be found as incidentaloma also. Then go for the thorough examination and positive finding. So just finding out the next case, a 40-year-old female reports of husky voice, something foreign body sensation, and found to have a thyroid nodule. So it's incidental finding again. Size is 1.5 centimeter and dominant nodule. There are two nodules, but dominant one is the right side nodule. So now we can find that more and more yield is there in by examination. So now definitionally, incidental are defined as non-palpable nodes less than 1 centimeter. So this is not incidental, it is 1.5 centimeter, noted during surgery or imaging for other purposes. So they are less chance of cancer, but they can find on follow-up, you can find earlier incidents. Exceptional, sometimes FDGs can have a more chance of malignancy. That's why you should find the primary source also. Dilemma exists whether you should do symptomatic, anxiety. There is a lot of protocol issues. Some people don't follow the protocol. That is why endocrinologists should be the team leader in that. We should find out that we are managing thyroid more. We should be involved in the decision making also. So laboratory test, basically TSH is the primary test to be screened. If you are finding low TSH, you go for scintigraphy. If it is not so low, go for the ultrasound scan, go for the FNAC if required. I will tell you indications as well. Again, calcitonin is again controversy if you are finding a family incidence of MN syndrome and hypercalcemic issue. Ganapati sir will talk about approach to acute hypercalcemia. Even there you can find calcitonin can be one of the tests which can be utilized. Anti-TPO antibodies, it is done very commonly now, but you should only recommend in some people suspicious of the thyroid disease like Hashimoto disease. Don't keep on doing it every 6 monthly or yearly. It's only one time only. That is now having long-term issues also. Thyroglobulin is one of the important tests to discriminate the benign from malignancy, usually done as stimulated values, that is stopping thyroxine for 1 month, post-thyroxine thyroidectomy or ablation also. Scintigraphy, just for showing this is important. It's available mostly. It is usually done as iodine scan or as done by a nuclear technetium thyroid scan. It is done to assess the functional status of thyroid nodule. If you have thyroid toxicosis, it can be done quite early and doing. It can pick up cold nodule, hot nodule, toxic nodule and warm nodule. So you can find variations of nodule. Percentage of thyroid tissue uptake is also important. Importance of finding cold nodule is that you can do FNAC from that cold nodule. It is photopenic area. That is important to adjust the importance of treatment also. Hot nodules are less likely to be malignant, but still you should go for follow-up. Ultrasound is recognized as a gold standard investigation. We can find the composition, echogenicity, margins, calcification, shape, and the blood supply of lymph nodes. So just to show you how we are using our technology also, the composition, our software finds, so we have got Siemens 1, which gives you 15 mmH. So we are finding more yield with it. By radiology doing consistently, we find that composition, echogenicity, margins, calcification, shape are picked up. This is our own patient subset. We have found early incidence of nodule pickup, and we had found colloid cyst because machine learning is also coming up, because machine learns more and more, and we also learn through that also. Then radiologists help by which nodule can go for an early FNAC and which can be followed up for 6 months to 1 year. Suspicious nodule, you find rim calcification and hypoechogenic and taller than wider. That is also one thing. But follicular nodule, usually it will be well defined, solid and predominantly solid, and definitely has to be done FNAC if required. So again, suspicious ones I have summarized here for you. Hypoechoic, irregular margins, microcalcification, taller than wider shape, and extra thyroid extension also. When you find TSH low, don't go for anything else than ultrasound. You go for the nuclear scan, then go for ultrasound. So now patient comes with this report of follicular cell. The same patient comes with follicular cell. They are not coming with follicular adenoma or follicular carcinoma. We are again stuck. We are not given category 3, category C we can say. So we are not sure what is happening. So whether we can go for surgery, again we should know for the next step. That is why multidisciplinary approach is required. We have tumor board in our area. I work in a periphery medical college. We have got tumor board. Whenever doubt as that, we discuss with the team. So not every case, we pool the cases in 1 week or 2 weeks, we then discuss the case. This case we did discussion and we did a holistic approach. So we found that majority can be benign also. 3 months, 6 months follow-up, we can see whether we can go for complications. So FNAC is the most commonly done. When I worked in Amrita, we used to do FNAC ourselves only because we are trained in doing FNAC. I urge you, if you are not trained, please try to go for some sort of training. You can just, there is no age immune to training also. And endocrinologists out there, if you are interested, please, because ITS does workshops on training doctors, endocrinologists on training, but it is not licensed to be done. It's only for your own understanding. FNAC can be done and sent to pathology. So pathologists coming and doing it and radiologists doing it may be difficult. Sometimes you can also help them. So Sheshadri sir is interested in this, so we are able to help you out. So this is how we do it. 23 to 26 gauge needle. It is done without image training for palpable nodule and ultrasound guidance. Otherwise, reporting criteria is very much fixed. So we can find sensitivity, accuracy also. So this is the flow chart we usually do when long standing is there, when there is malignancy features are there. Then we are finding other symptoms of respiratory, you go for an early surgery. Otherwise, most often ultrasound radiology can be done repeatedly. Stratification systems, ATA, ACR THYROIDs, Corrigan and EU THYROIDs. We usually for the ACR THYROIDs classification. THYROIDs 1 is benign, THYROIDs 2 also not suspicious. THYROIDs 1 can actually have sample not sufficient also. So try to repeat if it is not coming sufficient. Then go for the surgery if it is mildly or moderately or highly suspicious. And if it is size more than 2.5 centimeter in THYROIDs 3, definitely you can go for an early ultrasound biased biopsy, or you go for a, so there is studies from Sujoy Ghosh sir from IPGMR doing liquid biopsy also, where they are doing some techniques to find out tissue biased techniques also. This is how we can diagnose. THYROIDs 5 more than 1 centimeter definitely has a risk. They should go for early ultrasound biased techniques. This is the summary of what I have told you. Risk factors, nodule size, ultrasound features can go for a FNAC. So when I ask FNAC, I usually tell this analogy, go for a fruit basket. Fruit basket, there are so many fruits. We never know which is the unripe or the cancerous fruit. I will finish first. This is how we can do by ultrasound, at least we can find out which is going for this thing. Then you can risk stratification and go for the next. I will finish in 2 minutes time. So finally you can find that when you have a category 6 Bethesda, you can have a high risk of malignancy, whereas category 3 only 30%. Category 2 is the safest of the lot, 0 to 3%, whereas category 1, though is 5 to 10, can have a chance of progressing to the category 3 or 4 early itself. Molecular testing, again done in selective centers. We do it in our centers in Amrita and some place in CMC Vellore are there. So there is FRMA test sequence and thyro sequence which you're doing for category 3 only, BRAF, RAS and RED PTC. Special populations are required to be special interest. These are the pregnancy, pediatric, elderly and men syndromes. This is a summary of the ultrasound features and going for the progression. This is how we can use our own way of approach to find out the lesions. Last section, surgery, definitely indicated when you have got a follow-up required. Majority in hyperfunctioning cold nodules is not there. You can go for an antithyroid drug, radioiodine therapy if required, and only selectively when you are not finding remission, go for a early thing. Otherwise, majority surgical not required, only follow-up required. Intermittent nodules, we can go for diagnostic lobectomy or molecular testing. This is a case publication from Indore, which was done, published by the team there. They found that long-term patients can find out yield by doing follow-ups only. And newer tests like galectin-3, HMBN, they are all described. They are overlap between the follicular and differentiated thyroid carcinoma. Newer technical elastography is also coming up because even liver fibrosis are found out. Similarly, elastography can help in your own ways also. Last, on follow-up, this is how you can do thyroglobulin if required for follow-up, we can do it, but definitely not indicated in everybody. Cervical ultrasound is very easily done, and if required, get the follow-up done. Red flags, recent increase in the size, new lymph nodes, and development of dysphagia. These are 3 readily recognizable red flag signs for the malignancy for progression. This is the 88 given you the. I'll conclude my slide. Thank you very much for the kind listening.
So that was quite wonderful, wonderful images, wonderful oratory. You kept it short and simple and made it visually appealing to our audience. Now, if we have any questions, we would like to take them. Anyone? Sir, I have a question of my own. Sir, if a Bethesda patient, when you are going for Bethesda classification and it comes out to be indeterminate, Sir, after how much time duration do you repeat FNAC? Is there a
so
window?
correct. So same area, if you have a nodule done, usually I don't repeat it till at least 3 months. 3 months is what usually done, but individual variations do exist. There are some people, I think we work in a place where majority of people work in the Gulf also. Some people come for the evaluation only for the nodule showing Bethesda 3 from Gulf. So in that case, I think I asked the radiologist, are you comfortable in doing the ultrasound the same area and finding out? Second opinion we can take and get it done. That is one way. So that will help you in getting the thing. Second thing I have not put in the slide is called microwave ablation or radiofrequency ablation. It is coming up in a great way. Korean guidelines are there regarding thyroid nodule. RFA and microwave ablation are not our forte. But if radiologist is commenting, the patient is having increasing size, not malignant, they have to reduce the size somehow, then you can go for a evidence-based approach. Because ATA 2026 has come with recently some approval for the microwave ablation selective cases also.
I think this concludes our session, sir. Thank you.
Thank you very much.